ICG, the user acceptability as well as the utilization is very less. So that's where the current modifications, most of them come into. In 2018, Dr. Giridhar and many of us here were co-authors in the earlier PCV diagnosis and management evidence. There were 21 recommendations in that, starting from what all are the various diagnostic features. Is ICG necessary? Can OCTA pick up? Can OCT pick up? And also different types of management protocols. If there is subfoveal polyps or extrafoveal or extramacular subretinal hemorrhage, what are the different types of protocols which can be used in that particular 2018 publication. And this is a flow chart which describes all of them in one slide as to how we can have an algorithm for different stages or diagnosis and treatment. And this is one case where in the earlier times when we had PDT, and if you had a patient like this, the typical recommendation would be that you have to do PDT in patients with PCV. This was the FA and ICG to confirm the diagnosis as well. And as you can see on the ICG, in the right side, you see these polypoidal lesions, very nicely seen on ICG. And ICG was kind of a must for the diagnosis of PCV. And this example is showing that while you may give anti-VEGF, sometimes it doesn't work, and you have to do PDT and there is regression of polyp. But now, as we are aware that ICG is not routinely performed, so we have the non-ICG based criteria and published by Jimmy Chang and the Asia Pacific Ocular Imaging Society. And this is a very, very important publication, I would say, which validates many of the OCT findings which can help in the diagnosis of PCV. So in this, there are these slides describe the various features, but if you want to specifically look at the sharp PED, which is over here, that is more than 70-degree angle at which you see. This one is almost 90 degrees on one side. So it's at more than 70 degrees on any side of the PED is fine. Not both sides need not be very acute. That is also the base to height ratio. If it is less than 1 or the height is much more than the base, then it's considered as a major criteria for the diagnosis of a polypoidal lesion. Then you also have a subretinal sub-RP ring-like lesion. So if you have an RP elevation and there is a ring-like lesion under that, that's also a major criteria for PCV or a polypoidal lesion. Then on the en-face, if you have complex RP elevation, that's also. Then there are many other criteria, double layer sign, you have a thickened choroid or a hallux layer, or a multilobulated PED. So the three major criteria, once again, sharp PED, sub-RP, ring-like lesion, and en-face complex OCT elevation. So what happens is you can do an FA, you don't have an ICG, but you see the OCT, you see these characteristics, you can diagnose PCV. The area under the curve, all three major criteria being present was more than 0.9. So I don't know, you want to say what feature is being described here? Is this thick choroid? Is it a tall PED? Or is it, let's say, sub-RP ring-like lesion? What do you see here? Very nice, excellent. So unfortunately there is only one, but I think this is one of the important major criteria. And this one is a sub-RP ring-like lesion here. So if you can diagnose this on your OCT scans, you are other important part was the management. Everyone was talking about PDT, but it was hardly being done, not available. So we have also recommended that earlier it was mentioned in 2018 that PCV should be treated with full fluence PDT, but now we have made it that due to non-availability of PDT, anti-VEGF monotherapy is the choice. And also the choice of available agents based on Everest Planet. Earlier when we were doing PDT, ranibizumab was considered the highest level evidence earlier, but then now we have modified it that aflibercept should be the preferred anti-VEGF agent. Just moving on a little bit to the newer anti-VEGF agents, brolucizumab is a new molecule. Many of us have started using it. The user experience is limited, and also the the level 1 evidence in PCV is so far not yet established, although Hawk and Harrier had polypoidal choroidal vasculopathy patients. Unfortunately, the ICG which was performed at baseline in the Japanese cohort, they did not do the follow-up ICG, so we don't have the full analysis of the efficacy of brolucizumab in the regression of polyp. But in terms of visual acuity gain, they did very well with brolucizumab too. So the point is brolucizumab can still be used for PCV because it's been looked at the cohort in the Hawk and Harrier trial. But if you are looking at polyp regression specifically, that data is not yet available in a level 1 evidence. So this is one of my patients who initially presented with a polypoidal lesion. Again, we should not call it as polyp. It's a polypoidal lesion in a branching neovascular network instead of a branching vascular network. And then this patient had received 3 injections of brolucizumab. Although the fluid was not there on OCT at 6 months, you can see that the polypoidal lesions are still there. But then after one more injection at 1 year, the polyp has regressed. This is the same patient OCT at presentation at 6 months, and at 1 year you see the polypoidal lesion has regressed. So in conclusion, now the updated guidelines include non-ICG criteria. PDT, because of non-availability, is not recommended. Aflibercept is a preferred choice, and further studies with brolucizumab would be helpful. Thank you very much.
Thank you very much, Raja sir, for the wonderful talk. So any questions from the audience, the panel?
Thank you.
So I have just a single question, like with the longer acting agents like brolucizumab, so if you're starting a treatment regimen, if after a month there's a complete resolution of the fluid, along with say if there's a regression of polyp based on OCT or an ICD, do you give the loading doses of 3 or do you start directly with the treat and extend in such patients?
Since the topic here is evidence-based, for the maybe Dr. Mona can also answer, but in terms of evidence, if you are asking, at least the label is loading dose, whether it's PCV or PMB. But if you ask the real world and the doctors who are using brolucizumab now, almost everyone is following PRN from baseline. And I would say new protocols have to be designed and further evidence has to be generated.
Raja, just a question. That patient you showed with the PCV, you showed at 0, 6 months and 1 year. What was your frequency of injection?
What was the second?
The frequency of injection.
The first 2 injections were given actually every month because there was more of a subretinal hemorrhage component. The fluid, and there was hardly any intraretinal fluid or even subretinal fluid for the hemorrhage. So the first 2 injections were every month. And then after 2 months the patient received the 3rd injection.
Thank you very much. Thank you. So Dr. Anirudh will not be able to make it because of some prior social commitments. So he has sent across a recorded talk, so we'll be playing that now.
Very good morning, and thank you very much to AIOS and to SHETH for allowing me to be a part of this instruction course on pachychoroid. I apologize I could not be in person, but here it goes. So we just talked about two important things of pachychoroid spectrum. And we all know that when you have such a patient, coming to the clinic, you think of several aspects which could be related to the pachychoroid. So jumping in directly into this case, I'm going to show you this patient who presents with pre-retinal hemorrhage and some orangish lesions which are present in the inferior macula. And on fluorescein and ICG, you find that there are three types of lesions. The lesion on top is that of an anastomosis, the two vessels coming close together, and over here you can see it below hyperfluorescent lesion suggestive of polyps. Now when you deal with pachychoroid, you will find it very commonly for these conditions to have an overlap. And that's why by this case I want to highlight that when you talk about pachychoroid, it's not just a thickened choroid with choriocapillaries compromised, but you will also realize that we have a number of pathologies related to the choroidal as well as retinal vessels going on simultaneously. Coming back to the clinical picture, if you look at the orange lesion and the hemorrhage above, it exactly correlates clinically, but you need imaging to be able to tell you exactly what's going on. And if you pass the OCT, you will find that there is an inner retinal hyperreflectivity, which is suggestive of a retinal angiomatous proliferation. There is a hyperreflective membrane beneath the retina and rippled RPE, and further the imaging shows you that there is a kind of a polyp at the bottom, and OCT passing over there shows you subretinal fluid with elongated photoreceptors. So you also have certain features which are very specific of PCV, which include tall PCVs and double layer signs, and these are some features which define the pathology of polypoid choroid vasculopathy, which is a part of the pachychoroid spectrum. Now, pachychoroid spectrum also consists of pachychoroid pigment epitheliopathy, which is basically a presence of pachychoroid which changes in the RPE. So you'll have RPE bumps like those shown in panels A and B, and you may have increased choroidal thickness, like in this panel C, you'll find that there is a pigment epithelial detachment with increased choroidal thickness. The choroidal thickening is also seen with hallowed layer enlargement, and PPE are conditions which can progress to CSC as well. Now, focal choroidal excavation is also a part of pachychoroid, and this could be associated with type 2 neovascularization. And you can have very good response to anti-VEGF therapy in case these patients are complicated by neovascularization. You could also have a combination of focal choroidal excavation with development of CSR, in which case you have hyperfluorescence corresponding to the RPE change. We are now in the process of quantifying ICG to look at the choroidal vessel hyperfluorescence. Already we have the choroidal vascularity index, or CVI, which has been developed to actually quantify pachychoroid. So we are now moving in the direction of quantification of the pachychoroid, in order to understand this disease more clearly. So this is how the CVI works. We look at the choroidal thickness and the choroidal vasculature, and we obtain matrices which give you more insights related to the choroidal pathology. So with this, thank you very much, and I'm really sorry I could not be in person, but if any questions, of course, you have the expert, Dr. Joyce, to answer all of them. Thank you so much once again.
Well, that was a wonderful talk by Anirudh. So, any points for discussion? Okay, so I'll go ahead with my talk. Okay. Can you have the slides, please? Yeah. So, good morning once again. So I think there might be a little bit of overlap between the presentation of Dr. Anirudh and mine. So I would primarily be dealing with the pathogenesis of the pachychoroid spectrum and also what all diseases form a part of it. So the phenotypes of this entity are characterized by the presence of pachy vessels along with diffuse or focal increase in the choroidal thickness and marked attenuation of the choriocapillaris layer. And the presence of these hypertrophic or congested vessels in the choroid, also known as pachy vessels, and not actually a thickened choroid under an area of reduced or absent choriocapillaris at the posterior pole, appears to be the most salient feature of this spectrum. And there are various pathogenesis that have been proposed for the development of these pachychoroid spectrum, and of these a chronic vortex range stasis and subsequent remodeling of the choroidal vasculature by intervortex venous anastomosis plays a key role. So this may sound a little complicated, so let me just simplify a little bit for you. So on the left-hand side, the image what we see is that of a normal choroidal vasculature. So in this we see the superior and the inferior vortex veins, which are very symmetric in nature, and they meet at the horizontal watershed zone. And the vortex veins, they taper towards the posterior pole. So this is how it is in a normal eye. Now if we take eyes with CSE, there is an asymmetric dilatation of the superior and inferior vortex veins with loss of these watershed zones. And there is development of these venous anastomosis that takes place between these vortex veins, and this is the primary pathogenesis of this disease. So these dilated veins along with chronic congestion can lead to secondary back pressure changes, which leads to long-standing structural damage to the RPE and the Brooks membrane. Gradually there is a separation of these layers happens, what we see on OCT as a pigment epithelial detachment, and the RPE pump may get compensated, or there may be a small microrip of the RPE that leads to the appearance of the subretinal fluid. Now after this, a choroidal neovascularization may arise in some of these eyes at the junction of these anastomosis. And there is an overlying chorocapillaris layer filling defect that is basically seen in eyes with, that is basically seen on OCT angiography. So this stage is known as pachychoroid neovasculopathy. And at the last stage, the tips of this neovascularization, they dilate in the form of an aneurysm, what is now known as polypoidal lesions, and hence the PCV development. So this is just an ultraviolet field ICG angio on an eye with CSR, which shows the dilatation of the superior temporal vortex veins from the distal end to the ampullar area. So now we will just briefly go to the spectrum that forms this condition. So at the baseline is the pachychoroid pigment epitheliopathy, followed by central serous chorioretinopathy, then peripapillary pachychoroid syndrome, which may actually form a subset of CSCR itself, focal choroidal excavation, pachychoroid neovasculopathy, and at the end polypoidal choroidal vasculopathy. So we will just go through each of these entities briefly. So pachychoroid pigment epitheliopathy, it represents the form fruste part of CSE. And on clinical examination, we can see a orpheal mottling at the posterior pole in the macular area, and which is very well recognized on IR imaging as well as on the fundus autofluorescence imaging. Now there is an absence of the fluid on an OCT at this stage. Now gradually once the RPE pump gets compromised, there is appearance of SRF, and then it leads to the development of central serous chorioretinopathy. On angiography, when we see there can be presence of a unifocal or even multifocal leaks in these patients, and in long-standing cases, there may be a widespread RPE damage, which is also known as the chronic CSR stage, and these patients may have intraretinal fluid along with gravitational cracks. Now the peripapillary pachychoroid syndrome, the primary pathological changes of increased choroidal thickness and the fluid, whether it can be a subretinal fluid or the intraretinal fluid, is primarily present in the peripapillary location. As we see in the ICG angiography, this dilated choroidal vein is present in the peripapillary location. So this can actually represent a subtype of CSR. Recently there was a very interesting paper from AIMS where they had evaluated eyes with peripapillary pachychoroid syndrome, and they found that many of these eyes, almost 80% of these eyes, also had simultaneous features of CSR. So they may actually form a subset of this disease rather than a separate entity of pachychoroid spectrum itself. Next is the focal choroidal excavation, which is a structural abnormality consisting of a localized concavity that is there in the choroid, which occurs in the absence of any posterior staphyloma, trauma, or scleral ectasia. The primary pathogenesis that is there includes a focal scarring and retraction of the retinal pigment epithelium in this location, which leads to formation of what is known as an inverse pigment epithelial detachment. Now because of this, there could be a further compression of the choriocapillaris layer, which can exacerbate the choroidal ischemia. That is why many of these eyes with FCE, we see the development of a CNVM, and that may need treatment with anti-VEGF injections. Next pachychoroid neovasculopathy, which is primarily a type 1 macular neovascularization without presence of any terminal aneurysms on ICG. It can manifest as a late neovascular complications of PPE and chronic CSR. The SVOCT scan typically shows presence of a flat irregular pigment epithelial detachment or the double layer sign that we normally call it, and there is presence of a hyperreflectivity in between the RPE and the Bruch's membrane. Now there will be presence of underlying pachyvessels in majority of these patients with variable amount of intraretinal and subretinal fluid. Now since many of these eyes have a very early network, it is very likely that we can miss it on an ICG. That is why OCT angiography is very crucial for identifying these early networks and treating it. Now the last stage is the PCV. This was actually first described almost 40 years ago, but it still remains a little bit of an enigma for all of us. And it was described as a distinctive clinical entity which consists of peculiar subretinal polypoidal lesions associated with serous or hemorrhagic pigment epithelial detachments. It is very common among the Asian population, and in 2021 the APOIS PCV work group recommended updating the terminologies from polyp to polypoidal lesions and from BVN to branching neovascular network to accurately represent the nature of the neovascularization. Now ICG remains the preferred imaging modality for these eyes, but as Dr. Raja also clarified that SVOCT can be utilized in diagnosing these patients with considerable accuracy. So just to summarize, the most salient feature of pachychoroid appears to be the presence of large hairless vessels under an area of reduced or absent choriocapillaris. The subtypes of the pachychoroid spectrum represent a continuous pathological process, and the knowledge of these features and pathogenesis of the different disorders within the pachychoroid disease may assist in the management of these patients. Thank you.
Thank you, Dr. Jay. That was a nice overview of the conditions. I think we can take questions after the crowd builds and after some time, because there's a lot of overlap between the things.
Next I would like to call Dr. Unnikrishnan Nayak for his talk on multimodal imaging in pachychoroid disease spectrum.
Good morning, everybody. So, as I said, there's going to be a little bit of overlap in our talks, but yeah. So the spectrum has already been described, but the main key feature I'd like to show in this, but this is a really nice picture. It's not ours, but all the features like the dilatation of the key choroidal vessels, the overlying changes in the inner choroid, and subsequently changes on top are demonstrated in this particular. So these are the commonality in the pachychoroid. And the entity first is, we have an entity called uncomplicated pachychoroid, in which we're deciding whether it progresses to the various other forms of disease. So basically, to know how the spectrum looks on the NFAS, the choriocapillary is called grainy sand appearance, the sacculus layer is called the spaghetti type appearance, and you have the ribbons of the hallux layers, the thickened ribbons of the hallux layers. So these are certain questions beyond the typical imaging that we look at. Why do you and how do you have to differentiate between each of the varieties of the pachychoroid? Do some of the signs and symptoms, signs have any meaning? And what is the most key essential diagnostic points? So we'll go to pachychoroid epitheliopathy, in which it's, as Jay has said, it's a forme frustrate form. So the key particular feature here is you see a large dilated vessel, and overlying there's an RPE change over there. This is the simplest way to put it. And again, looking at these slides, you see it's a very localized focal change in which there eventually it may lead on to an RPE atrophy overlying the pachychoroid spectrum. But this is a slide I'd like to show you. This particular slide, you see changes, you see a pachychoroid, there's an OCTA over there that shows the absence of a blood vessel. So what is this particular slide important for? I would say this. The high autofluorescence shows a large circular amount of fluid. So this is a point in which you would differentiate a PPE from a CSR, an old resolved CSR. That is absence of evidence of subretinal fluid. So that is how you differentiate a PPE from a resolved CSR. Now I'm just going to take you through why multicolor is more than just color. So it's a very typical appearance. Anything elevated has got a greenish hue, and we naturally associate that with the presence of fluid. So this particular picture, you can see some blue, some orange, some green, sorry. But this is interesting. From a multi-color, you can actually pick up the amount of SRF, the RP elevation areas, the point where you can find the drusenoid PED. So there's much more revealed in a multicolor than just a plain photography, and this could be useful in on-fast diagnosis. Here you can see in this picture the presence of fluid, but also in the multicolor you can make out the orangish lesions over here, which actually correspond to the RP changes in angiographic evaluation. This is a patient with a poor, unclear media, but the amount of SRF is brilliantly picked up in the multicolor, which corresponds to the changes in the OCT. Here you can see a small change in a different color over there happening, and this actually corresponded to neovascular net. So the multicolor did actually pick up RP abnormalities enough to pick up a PCN even. I'm just going to skip this slide. So let's come to CSR and diagnosis. So it's something very seemingly simple, but there is a lot of modifications and a lot of changes and new things that have been found out in the CSR, which has entered the origin of the pachychoroid family, I would say. So this is a typical description in which you see an enlarging blot appearance, and there's nothing great about this, but this is some of the interesting things. Autofluorescence. In acute CSR, you can sometimes look and find the point of leak by finding a hypoautofluorescent spot there. Why is this important? The potential avoidance of doing an FFA, there is an 80 to 90% concurrence with the hypoautofluorescence at the point of leak with the angiographic point of leak. What are the other reasons why an autofluorescence is useful? It historically defines the old area of SRF, which probably helps in differentiation between persistent and recurrent CSR. It also tells you this kind of autofluorescence is there and due to the fragmented photoreceptors also. Autofluorescence also detects the area of a tract which is seemingly diagnostic of pathognomonic of CSR and confluence. So this is another important point what imaging tells us, multifocality. Why is multifocality an important point? It shows the progression of CSR to the next stage, and this is the next stage. So multifocality, you can see there are localized areas, but the intervening RP is normal. You can find that out in the autofluorescence. And then when the disease becomes more contiguous, the intervening RP also gets involved. So you have the disease process changing. That is singularity to a multifocality to intervening RP loss, and then you have the condition called DRPE, where there is widespread RP decompensation. So even in CSR, there is a progression, and for us basically, I think autofluorescence could be the most important tool to differentiate the various progression and the various types of CSR. So that's it over there. So again, I'm saying this is the changes that happen between multifocality, tracks, continuous damage, and finally decompensation. Okay. So I like to call this missing the point. This is what we were used to do in CSR earlier. When we used to do focal laser at the point of leak, but the whole I'm nowhere near finishing, unfortunately. So
that's fine, so you can continue.
I'll take another 6 minutes or something, and then I'll stop when it stops.
No, you can continue.
Okay. So the whole point is that CSR is not a focal disease. The whole diagram here is what I'd like to show, that you have points of larger areas of choroidal damage, smaller areas of RP damage, and a point focus in which it leaks. So the concept of being a focal disease is not there anymore. It should not be there for CSR anymore. So chronic CSR has certain conditions in which eventually it leads to atrophy, cystoid macular degeneration, and schisis. Just going to skip that. There are some important signs or nice signs to look at. One is a vacuole sign in which you see a hypo-lucent area between the fibrin, and that is an indication. So why are these important? They are pointers towards the leaking or the affected PED. Probably they could help in doing an angiography less treatment of CSR if it is amenable to focal laser, location-wise. And this is another sign, it's called dipping, where the neurosensory retina kind of dips towards the point of leakage. And you can see in all these pictures, there is a dip in the neurosensory retina, again like an arrow pointing towards a leaking PED. The end result of all these diseases, chronic RP decompensation, chronic RP fluid is foveal atrophy, and that is the sight-threatening factor. So this is another, as we said, tall PEDs, but this was a CSR, hopefully a CSR PED which is so fluid, and eventually on top of that you have a small area of severe atrophy, severe thinning, and this is called an RP aperture when it happens at the top. And it leads to an increased choroidal transmission, and on the angiography you see a hyperfluorescent area which could be mistaken for a vascular lesion. Eventually, when you have a decompensation of the RP on a PED, you could have conditions like cystoid macular edema happening because of decompensation. So this is another condition, it's called a choroidal cavern, where you see a circular roundish lesion at the area which is not like a choroidal blood vessel, it's larger than a choroidal vessel, and it has thin hyperreflective walls. Choroidal rift is something new that is being discovered. It's instead of being a round lesion, it's a confluent hexagonal lesion which is perpendicular to the RP. This is what a choroidal rift looks like. It's a confluence of empty spaces and immediately beneath the RP. And it's either described as polygonal, hexagonal. So we have some ICG features of CSR. The most important features, I will just have a few videos over here. And so I'd like to just stop this video over here, and I'd like to point out to this area. So on angiography, ICG angiography, you can actually see the area of chorioacapillary hypoperfusion. This is something that we really don't look at when we do ICGs. You can see all the choroidal thickened vasculature, but this particular point, and later down the line you can see that the leak actually starts overlying that particular point over there. You can see it. So this is the correlation between the pathology, the hyperperfusion in the choriocapillaries with the overlying pinpoint fluorescence that we are all very used to. So again, this is the still of that. You can see the area of the choroidal hypoperfusion over there. Hyperpermeability is defined and described by the presence of very thick vessels on the ICG. I'm just going to, this is just another where we can actually see the thickened vessels happening at the area of the future or the point of the CSR. The presence of PEDs, punctate fluorescence, and washout is a feature. I'll just show you what a washout looks like. This is a hyperfluorescence happening, and you can see in the late phases of the ICG that area gets completely washed out of dye because at the end of the day in a hyperpermeable, so there's a faster circulation and the dye gets washed out earlier, the ICG gets washed out earlier. So, and this is something that was very interesting, and there's a lot of work going on. It's called dual leaks. Technically, you describe an ink blot only on an FFA, but sometimes you get an ink blot also on an ICG. So which is by the characteristic nature of the dye of the ICG, you're not supposed to get an ink blot. It's supposed to be a staining pattern, not a continuously leaking pattern. And therein we'll go to the next pathology that happens. It's called the FIPED, a flat irregular PED. That is something that has probably a neovascularization underneath it. So why is it important to diagnose FIPEDs? Because if FIPEDs enlarge or laterally elongate, it means it's harboring something underneath, and that is the next thing in the spectrum called a pachychoroid neovasculopathy. That is, a pachychoroid neovasculopathy is a type 1 lesion which is under the RP. It's a next natural progression of a CSR happening. So this is a very interesting.
If you can sum up in 2 minutes.
Yeah, I just showed 3 slides or 4 slides with different 2 conditions. So PCN, we're just looking at pachychoroid neovasculopathy. Type 1, you see the blood vessels over there, and you see this particular lesion, but what the main thing is that these are things that are diagnosed in the OCTA much better than the angiography. So this is another case of PCN where you see a small vasculature. You can see the lower bottom slide over here with elevations of a double layer sign. So a double layer sign is a typical probable lesion which could be harboring neovasculopathy. So I think I'll just stop with these things. PCV is a very extensive topic. Some of it has been covered. So thank you for that. I'm free to take any questions later. Thank you.
Thank you very much, sir, for the wonderful talk on multimodal imaging. Maybe we can take the questions at the end after all the talks are over. And thank you very much, sir. I think you have been gracious enough to cover up the talk of Dr. Anand Rajendran also. That is one. So now I would like to invite Dr. George Manath for this talk on management of CSCR.
Good morning, everybody. Let's see on some thoughts on management of central serous chorioretinopathy. We all know that it's generally a self-limiting disease with good prognosis and outcome, but we have difficult cases like this where you have a chronic CSR with diffuse RP epitheliopathy, or you have a subfoveal pigment epithelial detachment with cystoid changes, again a challenge to manage, or you have such kind of bullous exudative RD and a fibrinous variant of CSR. And these are some of the challenges. Let's look at the management part. So we all know that the laser treatment in CSR with a good prognosis is if the serous macular detachment persists beyond 3 months, or if it recurs with visual defects, or the other eye has a permanent visual defect due to chronic CSR, or if the CSR develop chronicity signs which we just discussed on, which we just saw now, or patient has any occupational or other needs which require early restoration. So let's start with the most simple treatment. The focal laser is the commonest procedure done for central serous chorioretinopathy, where the early phase of fluorescent angiography, the point leads are treated with just 2 to 3 burns, grade 1 to 2 burns based on the early phase of fluorescent angiography to treat these points. This resolves the fluid or hastens the recovery, but it doesn't change the natural history of the disease or prevent recurrences. So that is about focal laser. A new modification of the focal laser, we have now the subthreshold micropulse laser, wherein the yellow laser is promising because you can do the subfoveal and juxtafoveal leads, which otherwise you are scared to treat with focal laser because of the foveal burn issue. Here these short pulses are given to the RP to stimulate the RP, but it doesn't cause the invisible burns, do not damage the overlying neurosensory retina. There is no collateral damage here. So this is safe, and multiple studies have shown the efficacy in treating with invisible burns. The problem is different study uses various parameters. There is no uniformity of treatment parameters in various studies. So we need further studies to have a uniform parameter with yellow laser, 577 micropulse subthreshold laser. So coming to photodynamic therapy, we know with Visidyne it causes a short-term choriocapillary hypoperfusion, but on a long term it causes the remodeling of the choroidal vessels, and it takes care of the choroidal hyperpermeability and congestion, which is the underlying pathology for central serous chorioretinopathy. So no more recurrences except in less than 10% of the cases for following half-dose or half-fluence PDT. So both half-dose and half-fluence are shown to be equally effective and better than standard fluence PDT. So our results as well as from the other centers have shown almost 90% recovery, visual and functional recovery in chronic central serous chorioretinopathy. So let us see some case examples now. So when you have cases like this with large subfoveal serous PED and subretinal fluid in both the eyes of this patient, angiography shows this kind of choroidal hyperpermeability or subfoveal leaking PED, you are left with no other option. You can't do a micropulse or even focal laser. So in such situation, this is pre and post treatment. You can see after half dose PDT in this case, the PED is gone, the fluid is gone, the normal foveal contour looks decent and 6/6 vision. So now the near concept of ultra-wide field ICG, Mirante or other images have shown that there is a congested vortex veins in the corresponding quadrants of choroidal hyperpermeability.
probably is there an outflow obstruction in chronic CSCR. So that concept, along with this venous overload choroidopathy with intervortex anastomosis, the macular anastomosis that we see is actually a compensatory mechanism to take care of the peripheral vortex vein congestion, which is supposed to be the pathophysiology. So let us look at a case example here to prove this hypothesis. This right eye chronic CSC, left eye again chronic central serous chorioretinopathy. This patient was seen for 3 years, was on follow-up. One fine day he developed a bullous retinal detachment, inferior bullous CSC with exudative RD, and these multiple leaks on fluorescent angiography, and peripheral choroidal detachment also in this patient, and CDs, and like how we see in a uveal effusion syndrome with exudative RD and peripheral CDs. You can see the thick fibrinous exudation under the macula in the right eye, and even the ultrasound shows the peripheral serous CDs and exudative RD. So this is post multi-spot PDP to the areas of laser, half-fluence PDP, and the peripheral CDs and the detachment and the exudative RD as resolved. Another case here, diagnosed as uveal effusion syndrome, and was underwent vortex vein decompression surgery and was treated with steroids. The right eye of this patient shows a posterior choroidal loculation of fluid in CSC and shallow subretinal fluid. The other eye had presented with a macula of total retinal detachment with a retinolendicular touch following vortex vein decompression and steroids. So in this case, we were left with no other option than to go for a endodrainage, vitrectomy, endodrainage for CSR, and silicone oil implantation. And under silicone oil, you can see the attached retina. Though a little extreme measure for a CSR case, there is no other option here. So under silicone oil, here you see the other eye fluorescent. These are misdiagnosed of uveal effusion. This is typical chronic central serous chorioretinopathy in the other eye. And even in the left eye, there is, these are the bands under the silicone oil, and there is diffuse leakage in the supratemporal area, which was treated with multi-spot laser, and there is a resolution under, this is under silicone oil, attached retina, and there is a resolution of, and angiography at this 3 months doesn't show any leakage, except for the laser marks that you see atrophy, and there is no leak. So silicone oil removal is done. So this extends to the extreme of CSR management. So just to touch upon the eplerenone, we have mineralocorticoid antagonist, which blocks the mineralocorticoid receptors in the choroidal vessels. So it's given a 50 milligram dose for 3 to 6 months. Initially reported to be a promising agent, but in a randomized trial, it was shown that it's not superior to placebo in the treatment of chronic central serous chorioretinopathy. Even our results showed only around 20 to 25% resolution in chronic central serous chorioretinopathy. Lastly, some of the poor predictors, if you see these kind of OCT signs on cystoid macular degeneration, the visual outcome following any of these treatments that we discussed now is going to be worse. And even in acquired vitiliform lesions like this overlying PUD, it is going that after, you can see after PDT, it is persisting and it's not going to resolve. So to summarize, focal laser is reserved for serous macular detachment in CSR more than 3 months with extrafoveal point leads. Half-fluence or half-dose PDT is the current gold standard for chronic CSR. Subthreshold micropulse yellow laser is promising for juxtafoveal subfoveal point leads, but it needs a refinement of treatment parameters as of now. Eplerenone is an option to be reserved where none of these other treatment modalities are working or not available, and understanding the mimickers of CSC or OCT biomarkers important pointers to treatment outcome. Thank you for your kind attention.
Thank you very much, sir, for the wonderful talk. Now, as we know, PDT is not available since the past couple of years in most parts of the world. So management of these pachychoroids has taken a backseat, and it's really challenging in this era. So I would like to invite Muna ma'am to give her talk on real-world case scenarios
in PNV and PCV management in the absence of PDT?
Good morning. Thank you, Jay, for inviting me, and thanks to all those who have come in the morning to attend this session. I'll just spend a few minutes on how we are managing PCV with no PDT urine. Not all of us are lucky to have this kind of response. There's one of my patients who just had one injection of bevacizumab and remained fine for years after that. And we do know that PDT in combination with ranibizumab has proven to be effective in terms of long-term outcome in IPCV. And we were all very happy with this, and all our cases were doing well. And this was also shown in the subsequent study. The PLANET study showed us that intravitreal aflibercept monotherapy was non-inferior to PDT or combination therapy. So that was also something good, that we now knew that if there is no PDT, we have the option of aflibercept. We also showed this in our own study where we could use aflibercept successfully in patients who had multiple sessions. This lady had a large PCV lesion, had multiple sessions of PDT and anti-VEGF agents, and finally with aflibercept she remained symptom-free with the eye being quiet. However, aflibercept, PDT, they are all expensive treatments. So a study from our own institute showed that combination of any anti-VEGF agent along with focal laser, if you image and find that the patient has an extrafoveal polyp, you don't need PDT, you can do focal laser. So this is a study that we did from our own institute which showed that focal laser was effective in treatment of extramacular polyps. And this was also shown in this large study from Kochi, which showed that multiple sessions of PDT as well as laser for extrafoveal lesions was fairly successful. And this again is a case of mine who presented with a large submacular hemorrhage. I displaced it with just a bubble of C3F8 gas because we hadn't imaged the patient earlier. And then after the bubble displace, you do an ICG and you find that there are a small cluster of extrafoveal polyps. You don't need multiple sessions of anti-VEGF. One session of focal works. And then this is a patient I just saw last week, and probably the largest feeder vessel I've ever seen. You see this thick feeder coming from the choroid. You see this on the OCT-AB scan. The eye looks otherwise quite quiet. She's had multiple sessions of anti-VEGF injections. I did an ICG, and if you look at the ICG, you see this is the feeder, but you see these little clusters of extrafoveal polyps. So this is a case where you image and then you do the focal treatment, and chances are the patient will manage well in long term. If one was to do a PDT, obviously we would treat the entire lesion. This is another elderly gentleman. Sometimes we see PCV in a thin choroid. This gentleman had presented with a subretinal hemorrhage many years after apparently successful treatment of CNVM with anti-VEGF agents. We did an ICG angiogram, and you see that though the feeder vessel is large, there's a large plaque, there are some extrafoveal points that you can very easily treat with focal laser. And now the new drug brolucizumab, there have been two major studies which have shown the short-term results as brolucizumab being effective in the treatment of PCV. However, our concern about post-injection inflammation, especially in women, remains. Our Indian study, of course, had no side effects. This case I borrowed from Mahesh Gopal Krishnan, who had a patient who was treated fairly successfully with a combination of PDT Accentrix, was doing well, and developed a recurrence. By then, PDT was no longer available. Being treated with Accentrix, the response was not too good. This was what happened. It was more that the Accentrix was feeding the lesion. And then after an injection of brolucizumab, the lesion flattened and remained stable. Which comes to the last case, do I miss PDT with all these new drugs? Yes, this is one case that's been giving me nightmares. This elderly lady who presented with 6/6 vision in both eyes, and this was her picture in the left eye. She had this huge pigment epithelial detachment. The OCT angiogram shows the cluster, the PCV cluster in the peripapillary region. You see the PCV lesions growing under the surface of the PED. This was her picture at presentation when she had a vision of 6/6 with a blur. You see these PCV lesions? This was the dramatic response after one injection. After 2 weeks, she rebounded like this. I waited for a bit because I felt there was an exudative response, settled down. Then we gave her Eylea. She responded. After the next injection of Eylea, she rebounded again with a large fibrinous reaction and the beginning of a subfoveal RP rip. And this continued. And despite our treatment, there was a very erratic response to Eylea. So then I said, why not try Pagenex? Everyone says Pagenex does well. And this is what happened after Pagenex. It's almost as if, again, Pagenex was feeding the lesion. So yeah, this was her PCV lesion, the peripapillary lesion. You see the activity post-Pagenex. I did consult a few of our friends as to what to do. She had multiple RP rips as well, a lot of exudation. I said, this was her ICG, showing the large lesion like this in the peripapillary area. You see the peripapillary polyps profusely leaking. I said, let's go back to eccentrics. We tried eccentrics. And this is what happened after eccentrics. The region flattened dramatically. I was so happy. I said, let's give the second eccentrics, and then it grew again. So yeah, I do miss PDT because this is a case where we would have done well. So managing PCV in the absence of PDT aflibercept monotherapy is a good option. Brolucizumab may give better results, though my limited experience is not that great. But one thing we need to remember, the role of focal laser in the presence of extrafoveal polyps can be very helpful. Thank you very much.
Thank you very much, ma'am, for the beautiful presentation. Unfortunately, we are completely out of time for the session, so we may not be able to take any questions at the moment. But I mean, we can meet in the corridor, and if anyone has any questions, we can definitely discuss it. Thank you very much, and I would like to thank all the panelists for their wonderful presentations and talk, and they have been gracious enough to be a part of this IC. Thank you.